Tony, I want to thank you for joining us on our Scrubbing In podcast today.
My pleasure to be here.
And to introduce Tony to our audience, Tony Sestokas is the Chief Clinical Officer for Intraoperative Neuromonitoring, one of the service lines at SpecialtyCare. And I was so honored to do a little research about you prior to our talk today. And I think that for our audience that's listening on the podcast, I would love for you to kind of just briefly walk through how you got into intraoperative neuromonitoring, your PhD program, and how you chose that as kind of your specialty.
Well, it was an indirect route getting into intraoperative monitoring. My original career plan was to go to graduate school and study neurosciences, experimental psychology and neurosciences, to better understand how the brain worked, and ultimately to work in the area of brain science or neuroscience to advance our understanding of basic neural functioning. I started out in graduate school at Northeastern University in Boston, and subsequently did postdoctoral work in systems neuroscience at Brown University, and then after that a year and a half at Johns Hopkins School of Medicine. When I actually finished the second postdoc, I got my first real job, and it happened to be at the University of Maryland Medical System at the Shock Trauma Center, where my responsibilities beyond basic research included clinical work. We began to study the nervous systems of brain-injured and spinal cord-injured patients who were being treated at shock trauma, and to, again, better understand the underlying physiologic abnormalities that these folks had, and in an effort to help physicians taking care of these patients to understand what their longer-term prognoses were. Several years into that experience, my boss, who was a neurosurgeon at the Shock Trauma Center, asked me to actually come into the operating room and bring in some of the tools that we were using in the intensive care unit in the operating room, so that he could have some real-time information about the nervous system as he was operating on the spinal cord and on the spine. And that was my introduction to intraoperative neuromonitoring.
How many years ago would that have been?
That would have been in the late 80s, early 90s.
See, we were talking off mic before we started. So you're looking at 30, 40 years of working in IONM. How has technology improved or changed from when you first brought that first kid in and attached those first leads?
It's changed dramatically. The very first operations where we were providing information about nervous system function, we used instruments that were designed and typically used in a clinical neurology, neurophysiology laboratory outside of the operating room. So we ended up wheeling in very large pieces of equipment, finding an appropriate place for them in the operating room, and trying to use that technology as best we could in a very different environment. The next evolution of those systems came very slowly, actually. The commercial manufacturers of the laboratory equipment saw that intraoperative neuromonitoring was a new field, and they began to design some smaller pieces of equipment that would actually be easier to transport into the operating room and to use in an operating room environment. So they started working on amplifiers that were quieter and were more resistant to electrical noise artifacts. And that began the evolution of more sophisticated equipment that continues to this day. The very earliest machines designed for the operating room only had 2 amplifiers, so that limited the number of channels that we could record from patients during surgery. The next generation went up to 4 amplifiers. The next generation went up to 8 amplifiers. Again, this was in tandem with the development of computer technology in the 80s. And as the personal computer evolved and machines became smaller and more powerful, that also spurred development for the intraoperative monitoring equipment to the point where now it's the typical machine will have 32 channels of information that it can collect simultaneously during the course of surgery.
I mean, it's amazing for you to be able to see that transformation of miniaturization and speed, and probably even being able to store and warehouse all this data over this time.
Those of us who started out with 1 and 2 and 4 channel systems look back at those times, and sometimes we don't have enough sympathy for folks who complain about the limitations of today's equipment, understanding where we came from and the things that we had to do in order to expand our ability to monitor.
For our audience, Tony, could you walk us through what a young neurophysiologist who might just be entering the field, what is their day-to-day like, or what is that morning prep time before they go into a case like?
Well, typically, folks who are providing services either in a hospital environment where perhaps they're employed there, or in our environment where we visit different hospitals, they will probably know which case they're going to be monitoring the evening before, so that they can mentally start to think about what the risks associated with the surgical procedure are and what the appropriate test modalities would be for monitoring and protecting those parts of the nervous system that are at risk. The morning typically is a very early start. So if the neurophysiologist has to travel to the hospital, he or she has to factor in that travel time. Their mornings may start as early as 4:30 in the morning and include travel time to the hospital. Surgery may start at 7 or 7:30 in the morning, but typically the neurophysiologist will see the patient before that time and start to prepare the patient for the recording that's going to occur in the operating room. Depending on the complexity of the surgery may last as short as 2 hours, more typically 4 to 6 hours, and it's not atypical to have a complicated procedure run 10 or more hours during the course of the day, sometimes into the evening. And so the days can be long. The days can be very unpredictable in terms of length. So the neurophysiologist has to have that flexibility in their lives in order to make sure that they can take care of their patient regardless of what happens in the operating room.
What's the background of most folks that are coming into neurophysiology these days? They obviously have gone through and completed their undergraduate degree. What's next for them?
Folks coming into the field of intraoperative neuromonitoring come from a very wide range of backgrounds. One increasingly common entry point is an individual who's had undergraduate training in a biological science or a health-related discipline, and that individual would typically join a company such as ours and then go through a year-long training program in order to acquire the necessary skill sets and knowledge base to be able to perform relatively straightforward monitoring and relatively straightforward surgical procedures. We also have individuals making career changes and coming in from other professional career paths, including disciplines such as audiology, chiropractic. We have individuals who have trained as physicians in foreign medical schools and have decided that they don't want to go through the recertification process to practice as physicians in the United States, but still want to be involved in patient care. And many of them find this career opportunity attractive to be able to leverage their skill set and still take care of patients.
One of the things that I was impressed with when I first joined SpecialtyCare was our SIM-OR. What is it like for somebody who's joining SpecialtyCare? They would come to Nashville and spend some time going through some of our training processes here in our SIM-OR?
Those folks who are coming in through our training program would spend at least 8 weeks in Nashville. For most of those individuals, the SIM-OR is their first introduction to an operating room environment. most individuals will not have had any opportunity to understand what an operating room environment looks like. The advantage that we have with the SIM-OR is that we can introduce them to that environment safely and introduce basic principles of behavior in an operating room, understanding what needs to remain sterile, how to behave appropriately, even how to move appropriately in an operating room environment so that they don't interfere with the other course of activity in that room. So it's a true advantage to be able to see the operating room table, to see the various pieces of equipment that they will encounter in an operating room, and to not have their first experience and first exposure to an operating room be the actual OR with the patient in it.
What is it like for the neurophysiologist or the neurosurgeon who's participating in the monitoring when they need to alert that surgeon? I know that we got the opportunity to see a surgeon panel recently at one of our conferences, and they talked about kind of how that surgeon, they had this really tight relationship with that neurophysiologist or that neurosurgeon who's alerting them.
Effective neuromonitoring requires, of course, a good understanding of basic neuroanatomy and neurophysiology, but it also requires an understanding of the surgical procedure and as well as the anesthesia that is being used during the course of surgery. Beyond all of that technical information, probably the single most important factor in successful neuromonitoring is the ability to communicate effectively with the surgeon. Surgeon is focused on taking care of a pathology and really needs to have information provided that is going to be useful to that surgeon in the moment. So communicating information about changes in neurologic function, which is what we do, has to be concise and precise. The surgeon also has to not only hear that information, but has to trust that the information is accurate. And that trust factor develops over time. And surgeons will repeatedly emphasize the fact that not only are they reacting to that information because they know that the changes are significant, but they actually trust that the information is not artifactual, and that they can make sometimes very, very serious surgical decisions based on that information without hesitation.
How does the role of data come into play, like especially in your role? I know that we have a scope registry, basically database of tens of thousands of procedures. How is that? How do we take that data in intraoperative neuromonitoring and make it actionable?
Well, every single surgical procedure has to be documented, and that's true whether you're working for specialty care or in any other kind of environment where intraoperative neuromonitoring services are provided. I think the thing that makes the data collection and data documentation process unique for specialty care is that we archive that information in real time as it's being entered into the database during the course of surgery, and then have the ability to extract and act on that information not only during the course of surgery when it's absolutely needed to take care of that one patient, but we can look back at our experience across now close to 100,000 patients and procedures every single year, and ask and answer very, very specific clinical questions and clinical quality questions that otherwise would be very, very difficult to answer without actually having access to as detailed a database as we have through our scope registry. That information is used not only by the medical department and the quality department within specialty care, but it's also used by our operations leadership to improve the efficiency of the care that we deliver. And it's also very useful to individual surgeons to better understand their own practice patterns and what's happening to the nervous system during the course of their surgical treatment of those patients.
Tony, with the history of neuromonitoring, it seems like a lot of the early procedures were on the spine. Where is neuromonitoring going today as far as the breadth of procedures that we can be involved with?
Some of the very earliest monitoring that occurred, you're correct, was focused on spine, and specifically spine deformity correction surgery. So back in the mid to late 70s, new instrumentation was being introduced in order to allow surgeons to correct spinal deformities, largely in children, and they had to fixate the corrected spine with rigid metal instrumentation. This posed a risk to the spinal cord in particularly, and a risk of paralysis in those procedures. So the early monitoring was focused largely on those types of surgeries. As the technology developed and as the equipment developed, the indications for monitoring other types of spine surgeries started to grow. But there were also other areas of surgery where essentially parts of the nervous system were put at risk potentially by the surgical procedure, and surgeons were looking for ways to get real-time information about the function of that part of the nervous system as they were operating. This included operations on the brain, for example, during tumor resections in various parts of the brain, where damage actually could be devastating to a patient's neurologic outcome if the surgeon didn't know that there was a problem at the time that the problem was occurring. So we went beyond the initial single test approach to start looking at a number of different tests that could be applied during the course of surgery to specifically evaluate the function of different parts of the nervous system at the same time. And this continues to this day. As surgical technology increases, as the patient population that is eligible for surgery starts to get older, there's an associated elevation of risk of potential injury to the nervous system. So we're finding new opportunities and new needs as surgery develops and as the patient population starts to get older. For spine surgeries, brain surgeries, we've expanded to monitoring surgeries of the head and neck. There are a variety of vascular procedures where there may be potential injury, neurologic injury, where the tests that we have as part of our arsenal are available and can be beneficial to the surgeon in those areas.
For a person that's maybe thinking about a career change, or somebody who's just going through their 4-year program and looking at what they want to do, what are some organizations or groups that they should be researching or joining if they have an interest in participating in some form with neuromonitoring?
Well, certainly joining an organization like the American Society of Neurophysiologic Monitoring, which is dedicated solely to advancing education and career opportunities in intraoperative neuromonitoring, would be one organization to take a look at. ASSET, the American Society of Electrodiagnostic Technology, is another organization that is focused on technical assessment of nervous system function, not only in the operating room but also outside of the operating room. And they have a variety of educational materials that would help orient somebody who's new to the field to the various career possibilities.
And for a person that is working their first few years as a neurophysiologist, in particular on our team, what is their potential if they wanted to get involved in doing research or publishing research based on some of their efforts? In
our environment, where we're not only taking care of patients day in and day out, but are also interested in improving the quality of monitoring, not only for specialty care, but for the discipline at large, there are opportunities to collaborate in research projects. So we have a number of projects that are always ongoing. We present at national surgical and neurophysiologic meetings 6 or 7 times a year. And so we're very happy to include as collaborators young neurophysiologists or even older neurophysiologists who have an interest that goes beyond the actual hands-on care of individual patients, but it takes a look at questions that need answering for the field, and we're happy to include them as our collaborators.
Excellent. Tony, I want to thank you so much for agreeing to come on Scrubbing In today, and I really appreciate your time and your sage wisdom.
It's my pleasure. Thank you.
Thank you, Tony.
Thank you.
All right.